Oh, there we go. Just like...
It will take just a few minutes as the participants come into the webinar.
Yep.
We'd like to welcome everybody here today. And we have with us Professor John Stone. He's a consultant neurologist and honorary reader in Neurology, University of Edinburgh, and one of the leading FND researchers in the world. So we're really grateful to have you here with us as we're working on awareness for World FND Week. Thank you for joining us.
Thank you very much, Bridget. Thanks.
We were, just to kind of get us started a little bit, we were talking before we started some of the research projects that you have currently going on and some that you've just written about. One in particular has to do a little bit with, we spoke with Dr. David Perez yesterday with some of the structural, possibly structural changes and some of the fMRIs. Can you elaborate a little bit as you were part of that project as well?
Yeah, well, it was really David Perez and Indrit Begg and Caitlin did all the work really, but I think they'd asked me to take part because one of the things that I've been keen to promote in FND is the idea that in FND there's a problem with the software of the nervous system rather than the hardware. And so, for example, if someone has multiple sclerosis or brain tumor, then there is a problem with the hardware, and it's generally pretty hard to fix that in a brain. Whereas a software problem at least has the potential to improve. And that is still the case, but what we used to think of the brain as something that didn't really change. It developed when you were a child, and then when you got to sort of 16, 17, it sort of set and then gradually deteriorated as you get older. But now we realize the brain is constantly changing. And actually, if you use parts of your brain a lot or are unable to use them, it actually can grow or shrink. So this idea of software and hardware is a useful one, but it's also doesn't map on completely to what we know about the brain. So what this paper was about, well, there are a number of recent studies looking at, well, is there any change in the hardware of the brain in people with FND? Does it look like there's parts of the brain that aren't as big? And the answer is it does. So they're quite subtle changes. They're not the sort of thing you would see on a normal scan. But if you get a whole bunch of patients and compare them to controls, then there do seem to be some differences, changes in the brain, changes in the hardware, which are subtle. So it's what I would expect. I think it's important because it's further evidence of the FND as a real condition. It's changing the brain. People are experiencing it. I think that can, for some people, be quite validating. They think, well, yes, there are changes in my brain. I am really ill, and I get that. But I also, if you think about it long enough, it's also quite scary, the idea that your brain has changed and maybe some bits of it are smaller than they should be. And what can you do about that? And the message is that you can change it back again, potentially. So the paper was FND software and a hardware problem. And I think the answer is it probably is a bit of both. And most of the hardware problems probably come about from developing FND rather than the other way around, but we don't know that.
I think some of the things that are also important is that talk about is that the flexibility as we learn more about it, we're exploring different things. And so I think that should be at least comforting to patients that research is looking at all aspects of how the illness maybe does affect them. And like you said, I would assume that through like neuroplasticity, it still can change. So this isn't mean that there's not, which research does support that. So yes. I think that's really important. You'd also mentioned a little bit about the visual changes in a paper that you had recently worked on as well. Can you tell us a little bit about that?
So patients with the patients who have visual problems as part of FND, if they mainly have visual problems, they're mainly sitting in eye clinics rather than in my clinic in neurology, but there's actually lots of them, and they're really a quite a highly neglected group. There's been very little research on people who have quite often significant visual impairment from FND, and you can think, well, how does that happen? But so their eyes are okay, the eyeball is all right, their brain is structurally normal, but they cannot see, or the vision's blurry, or blurred on one side, or they've got double vision. All of these things are quite common. They're probably about 10% of patients in low vision clinics, I'm told by my eye colleagues. So I had the opportunity last year to meet a couple of patients who were completely blind from FND. They couldn't see anything. Their world was just black. And one of them had a number of other FND symptoms, but the other one, who was a 19-year-old, didn't have any. That was her main problem. And I was struck by how little there was in the literature about what to do. There's really nothing to sort of explain to clinicians, well, try this and try that. So we tried, the paper was describing treatment in both of those patients, and both of them, we had a successful outcome. They both got normal vision, one after about 6 or 7 years, the other one after about a year. And so that was very exciting. And of course, that doesn't always happen, but we talked about the things that had helped. And so looking at what we've done with types of FND where people have weakness, for example, we talked very explicitly about the fact that at times, although they had no experience of vision, they were seeing things, because actually that's the nature of FND, that the brain can work better than you think. So for example, one of the patients, he went into a shop and said, oh, I really like that AC/DC t-shirt. And he said that to his partner, which he'd obviously seen, but he hadn't had the experience of seeing it. So rather than making that a weird thing that he was embarrassed about and couldn't really understand, we encouraged him to look for those experiences and discrepancies and made them part of his therapy. Both of them benefited a bit from transcranial magnetic stimulation. Okay. So you put a magnet on the back of the head or a special piece of equipment called TMS, and it produces a visual experience, a brief sort of primitive visual experience. One of the patients was helped by hypnosis. But I think it was probably more about just talking generally about the diagnosis, helping them to really understand it. We used that film Inside Out, the Pixar movie, where there's a little characters inside your head. We use that to talk about how functional visual loss was working, because the little person inside your head who's in charge of vision had just given up and was not at the races, so those sort of things were helpful.
Well, that's fantastic. We have one question from one of our panelists, and she asks, can you tell me if there are no pain meds that help people suffering from pain who have FND? Yeah,
well, this is a really common issue, and because chronic pain is probably experienced by 60-70% of people with FND, particularly if they have motor symptoms of weakness or movement disorder. It's not part of the FND diagnosis, although really it is such a common feature that we need to be talking about it, as we are tonight. I have to say, the longer I'm a doctor, the less confident I am that the drugs that we have, particularly in this for FND patients, I'm less confident that the drugs are that helpful. I don't want anyone to go off and stop their drugs suddenly, or don't do anything like that. Could be dangerous.
Please don't.
But I think, and patients just can't believe that in this day and age, why do we not have a drug that gets rid of severe chronic pain? People are suffering horrendous pain. Why can't we get rid of it? And the answer is we just don't have good drugs for this. The only drugs that, and the drugs that can temporarily relieve it, like morphine and things like that, are ultimately a complete menace if you've got FND, and they actually can make things a lot worse because they affect your brain, and they don't provide any long-term benefit. So there are medications that can help a bit, or for some people a lot, But I meet a lot of people where the drugs are just not working properly, very well. And it's a very frustrating situation for everyone.
Well, you can see how it would create a cycle, right? Because as a patient's in pain, it's obviously going to start causing stress on their body and, obviously a lot of other problems. And so
Yeah,
it seemed like it would be just such a perpetuating cycle.
it is.
Do they find that some of the pain clinics, are they able to help with functional pain
Yeah, so
in
what
your
I'd say
experience?
is that the medication can help, and for some people it is very helpful. It depends what sort of pain you have. So, you need to see a doctor about that. It's a complex area. But I think I do see people with chronic pain improving. But I'm struck by how often when that happens, it's not necessarily the drugs that did it. It's usually some form of rehabilitation. It's normally patients who've gone from one understanding of their pain, usually it's some idea that some part of their body must be damaged, or they have trapped nerves or arthritis. They've gone from that, which is a perfectly understandable idea, and that's what I would, that's what I expect anyone to do if they're chronic pain. But they've gone from that to realizing that chronic pain, like FND, is actually largely a problem with the software of the nervous system. There's lots of very good evidence now that chronic pain involves increase in volume knobs and pain pathways at lots of levels in the brain. The person can't change those volume. They can't just suddenly turn those volume knobs down. That's why they're in pain. But over time and with rehabilitation and understanding that and lots of different techniques, I do see people who can crank those volume knobs down such that they have less pain. And so that definitely want to send a message of hope out there that I think chronic pain can be improved, and not to lose hope.
This might be a bad comparison, but you made me kind of think a little bit like Lamaze breathing for pregnancy and childbirth. I would think that some of those techniques are somewhat similar, right? Using other methods to kind of manage the pain. So would that be kind of a similar type?
Well, I think what you're talking about these are techniques where people are helping to recognize that they're in a situation where they're not in control of their own body and it's doing its own thing. But the techniques that are out there, the rehabilitation techniques, are there to try and help people get some control back. And you can only start to do that if you really understand and have some confidence about what is going on inside your own body. And of course, when you're delivering a baby, you do know that. But when you've got chronic pain, you've got to start with knowing where the problem is, I think.
Well, thank you. I know that's a big problem. We're starting to get a lot more questions in now.
Yeah,
So
I saw that, yeah.
One of them, a question, and this is asked quite frequently, is can FND go away completely and never return?
Well, the answer is yes, it can. And all of us working in this field do see that. But at the same time, we also know from studies is that quite often it doesn't, or it goes away and it does come back again. So for most people, it tends to sort of come and go. I think however long you've had it for, it does have the potential to go away completely. I mean, we've just done a study of patients who we followed up for 14 years in Edinburgh, who were my PhD group of patients. And it was quite shocking, actually, that about 80% of them still had some of the symptoms, that they'd still had some of the weakness symptom that I'd seen them with 14 years before. That's high. But not all of them were disabled by that. Some of them, they had the symptom, but it was in the background, but they were getting on with their lives and working and things. So it's a bit like if you go through periods of very, very, very disabling migraine, which stop you working, that's terrible. But if you have migraine now and again, which you can work through, it's not so bad and you can live with it. So often the aim is often to improve symptoms and make them in the background rather than necessarily make them go away. But they can go away. And some people, they do go away completely.
Well, I think now would be a good time also to point out that whether a patient gets better or not has nothing to do with their desire to get better.
No.
Sometimes I think that's been misconstrued by family members. It's not because they're not trying hard enough. Do you see that happen often, or even other clinicians thinking that, maybe a patient didn't try?
Yeah. I think what I'd say about that is that if someone's going to enter into treatment, they do need to have some understanding and confidence about what's wrong. That is important. And they do need to have some motivation to improve, or motivation for change. And that's a tricky thing. It's a bit like if you're trying to lose weight or something, it's hard to do this. It does require that person to be trying, but there's lots of people who try absolutely 110% and it doesn't make a difference. So trying, you're right, it doesn't, if someone doesn't get better, it doesn't mean that they weren't trying. If that makes sense.
Yeah, and I think that that's just important that we remind people of that. We've got a couple other questions coming in actually through Facebook. Normally we don't take questions from there, but I have someone that's willing to send them to us. Going back to the vision conversation we're having, they asked, could vision issues be caused by chronic headaches or migraines? Or another question to do with that would be, are vision issues all FND related?
Okay, so in fact, one of the patients I treated, I think her FND visual loss came about from migraine. We often see this interaction because migraine causes lots of neurological symptoms, but usually they come and they go. In her case, she had terrible migraine. She was spending most of the time in her bedroom in the dark. And one of the ways that we thought about what might have happened was that her brain had just said, look, I don't like the light because the light gives me migraine. And so the brain, as one of the reasons, the brain had decided just to switch off the monitor and not see anything. So migraine's a very important condition to think about that interacts very frequently with FND. And you've got to sort of pick it out of the whole picture because sometimes specific migraine treatments are important. Sorry, I've forgotten the other bit of that question. Visual symptoms in FND. Yeah, no, they're not always to do with FND. You might have glaucoma, or you might need new glasses, or have a cataract. So you've got to have somebody looking at that with an open mind. But they will often not. Eye doctors and opticians will often not think of FND when that actually is the cause. And patients spend a lot of time having tests they probably don't need to have sometimes in that situation.
Well, and I think it's important that, because as you mentioned, there's not a lot of work in that area. So we really appreciate that you're bringing some highlighting the visual changes that patients often see. So it'll come to, the attention of researchers that deal in that specific area of medicine and can maybe start getting a little bit more involved.
Yeah.
The next questions that we have are a few involving swallowing and swallowing associated with FND. I'm not real sure specific questions. I think they're just kind of wondering how those mechanisms, do they differ from regular symptoms, or are they the same?
Swallowing is interesting because swallowing starts with a voluntary movement that you make, and then it finishes with an involuntary one that's part of your gullet. Which you can't really control. So it's kind of an interesting symptom there. But people do get quite commonly symptoms up in their throat. One of the commonest ones is called globus, and that's a feeling of something stuck in your throat, even when you're not swallowing. Some people feel like a ball there. Or sometimes it's mainly when people swallow. And again, if you have that symptom, you've got to have it looked at. Someone has to look down your throat, see if there's anything there. There's lots of causes of it. You can get it from reflux and things like that, but it's quite common in FND as well, and it probably comes about because of the brain sort of shining this spotlight on that area, which you're not in control of. It's just doing it by itself, and it's drawing a focus to it, and then muscles contract, and then you get the sensation, and it's a horrible feeling, and people sometimes feel as if they're being constricted. It can cause anxiety. And there are people, so that's globus, and there are also people who have trouble swallowing. They, in the same way that there are people with FND have trouble speaking, they just can't. They've sort of, the brain's working too hard on it, on the problem. You know, most things our brains do, they do automatically. We don't think about them. We don't think about swallowing or moving our arms. And in FND, one of the things that many of these symptoms have in common is the brain's working too hard on the problem, and it does it in a way that's become involuntary and the person can't control. So the treatment is to recognize that and try and allow those automatic normal swallowing movements to come back.
Well, and Claire talked a little bit about swallowing in hers as well. Is it typically like an OT specialist who would help patients with learning how to swallow? Or someone has asked about how to stop spitting during an attack. Would that be the same kind of mechanism, or would that be something different? Would they still see the same type?
Swallowing is very much the domain of speech and language therapy, or speech and language pathology, I think you have in the US. We're actually getting together a network of speech and language experts to do some consensus recommendations in this area, because they are badly needed as well. We do have some very good resources, but we need better ones. Sorry, what was the question was about?
Someone, yeah, they said they have a difficult time spitting during an attack.
So some people during attacks get a lot of saliva in their mouth, and then they can't control their mouth, so it can build up. And sometimes people have trouble spitting, or sometimes saliva comes out involuntarily, which is obviously very distressing.
Okay. There's a question regarding, I saw a conference on YouTube and the doctor said the number of symptoms is high. Is a high chance to get better, is less if there's less symptoms. Do you think that that's true? So if a patient has more symptoms, then they're less likely to get better versus a patient who maybe has one or two?
I'm not sure we have the evidence for that. I think with some interesting evidence, I think there's people with FND do tend to have a lot of symptoms. On average, they have more symptoms than probably any other neurological condition. And it's exhausting for the patients to have so many different symptoms, and it can be, for everybody. But people with MS have a lot of symptoms as well, so it's not that, so you can't make a diagnosis just because someone has lots of symptoms. And there are people, particularly if people have a lot of have like 15 symptoms and they're very anxious about them, and they have, particularly if they have irrational fears that they've got fears that they develop, that they're getting a condition like MS, then they might have developed health anxiety on top of their FND. And you can have FND without anxiety or depression, but you can have it with as well. And if you have it with health anxiety, and that's usually a state where people just can't stop worrying about MS, and they sort of know it's irrational, but they can't stop it, then symptoms can multiply quite badly. And actually, that's quite a treatable condition, health anxiety, when I look for it, because it's not that common in its severe form, but when I find it, can be, you can really put that into reverse, I think. So I wouldn't be too pessimistic just because you've got loads of symptoms. It all depends.
Well, and I'm thinking of like non-epileptic seizures. We have a lot of people that only have non-epileptic seizures. Yeah. And so that would be considered one symptom. However, I can imagine that their rate of recovery is that much variable than. Yeah.
So I think there might be a weak correlation, but on an individual patient basis, it's not enough to say, things are hopeless for me, or, and that's the same for things like, how long you've had this for. People say, the longer you've had it for, the harder it is to get better. Well, there might be a little bit of truth in that if you take 100 people, but if you take one person, I meet people who've had symptoms for 10 years and they just haven't met the right person to try and help them get better, and then they do. So, or it's not been the right time, or there's been something else in the way, or, so I think this is a really variable condition where you can't, it's very hard to make rules, which is good because, I mean, it gives hope to people, but it's also, you've had symptoms for 10 years, but it's also frustrating when we can't give a straight answer to a question like, well, am I going to get better and how long is it going to take? Which is what most people want to know.
Definitely. But as you mentioned, there's always hope. There's no definite, I guess, when you're really dealing with FND. And so I think that's definitely a positive to focus on.
Yeah.
Another question that's been asked, and we do hear about this a lot, is there a genetic link? Do you want to touch on that?
Yeah, so there's very little research in FND specifically, but there's lots of research on conditions that are common in association with FND, like migraine or anxiety, and I mean virtually everything that human beings do, including being ill, has a genetic link. So your hair color, your height is genetic, and a lot of things like anxiety are strongly genetic. Migraine strongly genetic. So it would be very surprising indeed if FND didn't have a partly genetic contribution. But it's not something that you're going to definitely, you're not. People usually ask that question when they worry if they're going to pass it on to their kids, things like that. It's not like that. I do have families where more than one person's got it, or siblings, or mother and a daughter, father and child. So that does happen, but then it's quite a common condition as well. So yes, there will be, but we don't know in what sense it's genetic.
Well, and given the amount of patients that you see and have had access to, if it were a genetic type disorder that was being passed on to children, we would probably see it a lot more prevalent popping up than what we see just in the normal population.
We would know that, yeah. So I think it's like, I think it's probably similar to something like, high blood pressure or anxiety. If you've got a parent who's always been a worrier, well, you're probably more likely to be a worrier yourself, but it doesn't mean you're going to be, or it doesn't mean you're going to be have it as badly as them or whatever.
Right. Why we're kind of talking about
you've frozen.
Some other type of comorbid type things. Am I back? Can you hear me still?
Back. Yes, you're back. Yeah.
Okay.
Yeah.
I was just getting ready to ask about, we have a lot of people wondering about like ADHD, autism, excuse me, sometimes comes up. Have you seen any correlation or has there been any research on that?
There hasn't. I think there probably is a bit of a risk factor. I probably see it a bit more than by chance. But I think one of the difficulties there is, and I'm not an expert on ADHD, so I have to, take what I'm saying with a pinch of salt. But I think that some of the symptoms of ADHD can also overlap substantially with some of the other common comorbidities, and that means other things that people with FND get more than by chance. So, anxiety, for example, or people who've got trouble regulating their emotions, so that they are feeling good one minute and then they feel dreadful and upset and then they feel good again, and they don't know why they keep going up and down. It's not bipolar, it's just sort of emotional ups and downs. I mean, ADHD is definitely a thing, but I think the symptoms overlap. So I find it quite difficult clinically to really know that. But the bottom line is no one's done the research yet, so we don't know.
Right.
And autism similarly, you might predict it would be a bit higher in FND for various reasons, but it's not that common. It's it's like 5% probably, and diagnoses of autism and ADHD are in big flux at the moment, and we'll see where it levels out when people know where to draw the line with these things. It's very tricky. There's all shades of grey going on.
Well, and I think as they're learning more about those conditions as well, that kind of where that will come, if there's a connection to
Yeah.
both of them. I think are quite in the infancy of what we know about the conditions.
Yeah.
Kind of switching gears to another question, and we're starting to run out of time, but one of the members is asking if there are any tips on how to stop with self-focus element without help or support while you're waiting for treatment. And we often find, a lot of the waits for treatment are quite long.
Yeah.
In general, do you have any tips on what
I can
patients
see
can
that. It's a great
do at
question.
home?
How to stop focusing on the gait disorder, knowing it makes it worse. So the person knows themselves when they think about their leg length, they can see it getting worse, and they just, I mean, that's a good start, that the person knows it makes it worse. I mean, that's
Right.
you've got to the first step there. People try, I mean, what the physiotherapy would do, and I would try and discuss before you see physios, to think about, try and be creative with things that really gain your attention. So, for example, when you're walking, it might be music, it might be counting or speaking to somebody, it might be moving in a really odd way. So, for example, sliding your feet as if you're ice skating rather than normal walking, because then you're thinking about ice skating rather than stepping, or wobbling from side to side. Obviously, these are things that are easier to do at home on your own, but though, if you can open up those can start to open up possibilities, and you can start to feel perhaps a bit more fluent in your movement if you're doing something that's different to normal walking. So even things like, if you can manage it, something like skipping, for example, of patients who can find that they can skip but they can't walk. Try these things out, and they might seem mad and crazy, but they do make sense with FND and with the mechanism of FND, and can be really helpful.
Well, I think a good example of what kind of you're talking about too is the video that we've seen coming out of Australia, of the woman who couldn't walk but could run, and it's almost finding a different way to do that. I know some patients also will say they can walk backwards, but they can't walk forwards.
Yep,
so
absolutely.
Possibly working with ways that they can.
I've gathered together some of those. I've gathered together some of those videos on the video tab on my neurosymptoms.org website. You can see some of those.
Oh, perfect. And there's also on the FND Hope website, we've got some tips and things there too for anyone that's looking. So both sites, very helpful information with patients. I was going to look and see if we can take one more question. What is the next frontier of research? Is there an international association for FND, which we have mentioned, but maybe you could talk a little bit more about, and who is it for?
Yeah. Okay. Well, there is about. I mean, I keep saying this, we haven't. But we're going to launch an international society. It's called the FNDS, Functional Neurological Disorder Society. We're going to have. It's for health professionals. We want to work very closely with patient organisations, but we, as health professionals, we really need to get our house in order, and not just to put FND on the map, but also to work with each other, all the different types of health professionals that get involved: neurologists, psychiatrists, physios, occupational therapy. So the aim of that association is to promote scientific research, best clinical practice. And we had a meeting in Edinburgh in September 17 that we organised, and 550 health professionals came. There were some patients there too, which was great, and organisations. So there's going to be another meeting in Boston in June 2020, and it will be for health professionals. But if patients want to come, they will be, they'll be able to come. But we'll be talking about the science mainly and the practice. Next frontier of research. I think there's multiple. It's a very exciting time. I think we're looking at very great research, looking at brain mechanisms. For example, from David Perez, we're looking at, perhaps there will be there ought to be a big genetic study at some point. I'm personally, my excitement lies in treatment research. I think that's because I've always been interested in practical doing things. And I'm very excited to be involved in Glenn Nielsen's physio trial, which I think you heard about in another webinar. That's going to be the biggest trial of physiotherapy for FND by a factor of 10 over 5, I should say. Yes, 5 times bigger than the next biggest one. And we're going to need more treatment trials. We're going to need trials of multidisciplinary treatment, trying to make the case for having FND centres, for example, in the same way that we have stroke units, which provide good multidisciplinary care for stroke. I think we need the same thing for FND. It's about teamwork, having nurses and physios, all OTs, all doing the same thing. That's what strikes me as being where we should be heading.
That's fantastic, and it's great to see everyone coming together, working towards that common goal. And that was one of the concepts that Dr. David Perez and several of the others have spoke about, is the importance of working together and how helpful that has been. And so we really thank you for the time that you've given us and helping to educate patients and other medical professionals, because it's really made a huge difference in the lives of patients and in a fairly short amount of time. It kind of seems like everyone was kind of waiting for everything to move forward. And while medicine does take a while to do some of these trials, it is moving quite quickly.
Yeah, it's not fast enough for some patients. I know there are many people out there who can't access anyone who knows anything about this at all, and they just get a shrug of the shoulders. But I think things are slowly changing, I would say, or maybe more quickly changing. And the science is really helping. And I'd say we have a very healthy international community where there aren't, at the moment anyway, there isn't a lot of politics or, we're all supportive and interested in each other's work. I think that doesn't always happen in a particular condition. So that's good for the field. And also, I think it's really crucial and great that we've got this relationship between patient organizations and the researchers working together. That doesn't always happen either, and I think that will really make us a lot stronger in terms of making the case.
I agree. Thank you very much. We appreciate your time, and we appreciate everything you do for patients in general. So thank you.
Likewise, Bridget, yeah.